Good evening and welcome to the American College of Surgeons webinar on Global Codes Data Collection. I'm Vanita Alapali, staff with ACS, and our presenter is Dr. Linda Barney, the chair of the ACS General Surgery Coding and Reimbursement Committee. Please note that this webinar is being recorded and will be posted to the ACS webpage within a couple days. At the end of this presentation, we will provide resources, including the address for our webpage. We have also created a one-pager on this issue that you can download from the Handouts tab on your screen. All lines are currently muted. If you'd like to ask a question, please make sure the audio controls are enabled. Then use the hand raise function, and I'll open your line at the end of the presentation. You can also type your question in the Questions tab. So with that, I'll turn it over to Dr. Barney.
Thanks, Vanita. So over the next hour, we hope to review the key elements of Global Codes reporting, speak briefly about how we arrived at this point, review the reporting requirements, address some frequently asked questions, and then recap and review some available resources. So what's the bottom line? This is a new Center for Medicare and Medicaid Services Global Codes policy. You report information to CMS on the number of postoperative visits that you provide. CMS will use reported data to improve the accuracy of Global Codes values. 9 states have been selected for reporting, and the start date is July 1st, 2017. So what's the background? Prior to 2014, CMS expressed concerns over the accuracy of global code values. At that time, CMS finalized a policy that would have transitioned all 10 and 90-day global codes to 0-day globals. Over the next year, the ACS fought this policy through diligent and sustained efforts on the legislative and regulatory arenas, and we were able to make significant headway. In 2015, MACRA came about and prohibited CMS from transitioning 10 and 90-day global codes to 0-day globals. The other consequences of MACRA are that CMS must obtain information needed to value surgical services, including the number and level of visits from a representative sample of physicians. The data collection was slated to start no later than January 1st, 2017. CMS must use this data to improve the accuracy of global codes starting in 2019. So I'm sure many of you are familiar with the global period. So surgical procedures may have a 10 or 90-day global period during which follow-up postoperative visits are bundled into the payment for the procedure. 90-day global periods also include the services provided on the day before the procedure. Procedures with a 0-day global period permit physicians or non-physician practitioners to bill separately for any postoperative visits after the day of surgery. By convention, physicians who furnish the entire global package of care, which includes the usual pre-op, intraoperative, and postoperative care, enter the appropriate CPT code for the surgical procedure only, and postoperative care for 10 or 90 days is bundled into the RVUs, or global payment per procedure. So if you look at this slide, you can see this is a slide taken from the RBRVS data manager that's a product of the AMA. But the RBRVS, the resource-based value system, was started in about 1992. And since that time, we've basically taken codes and stripped down the codes to the elements required in all of the elements that are required to make up a resource value unit. So you can see there are some times there in addition to these numbers of post-operative visits. So in this slide, you can see there is a post-operative day discharge management. There are 3 separate levels of post-op hospital day visits, and then there are 2 levels of post-op office visits. So what this slide depicts is the typical patient for the service provided, and individual circumstances will vary. So the time data and the number of postoperative visits should not be construed as absolute, but these are the typical visits that are associated with a given procedure. So this slide just depicts a laparoscopic partial colectomy. Again, you can see that there's a discharge day, 2 separate levels of hospital visits, of which there are 3 99231 visits, and then 2 separate office visits. So that brings your total postoperative visits to 8. If we look at a laparoscopic cholecystectomy, for example, a lap chole, which is a predominant outpatient procedure, has a half to 1 99238 discharge day associated with it, and 2 postoperative office visits, whereas an open cholecystectomy with cholangiogram has a discharge day, 4 hospital visits, and 3 office visits. So those were the typical number of visits that were associated with those codes at the time that the codes were created and subsequently revalued. Okay, so let's talk a little bit about our reporting requirements. So as part of this process, CMS finalized a 3-pronged data collection methodology for these global codes. The first would be the claims-based reporting, which we're going to spend most of our time on this evening. In addition to that is a practitioner survey, and then the third component is direct observation of sites, including accountable care organizations. So who, what, and how in claims-based reporting. So the who is groups of 10 or more practitioners, and we'll address this as we go forward. The involved states are Florida, Kentucky, Louisiana, Nevada, New Jersey, North Dakota, Ohio, Oregon, and Rhode Island. And these were states based on distribution of services and census data to try to get a representative sample, as was mandated in MACRA. So what will be collected? Postoperative visits for 293 codes. These codes are those of high volume and high value. So they're reported by more than 100 practitioners annually, have a high volume greater than 10,000 or more, and high allowable charges about 10 million. How will you report? You'll report via CPT code 99024 for each postoperative visit, and the start date is July 1. So again, here are the 9 representative states. Who reports? One of the most challenging questions for us has been the definition of practitioner. CMS defines a practitioner as physicians and non-physician providers, including those working under supervision. So basically, this is anyone who can independently bill Medicare for services. So that includes occupational therapists, physical therapists, social workers, some dietitians, a lot of other people besides PAs, nurse practitioners, CRNAs, and individuals that we usually consider practitioners that might be part of our group. They define a group as a practice who shares the following between 2 or more practitioners, not necessarily at the same location or address: business or financial operations, clinical facilities, records, or personnel. So within that is what we would normally consider a group under the tax identification number. But this expands it a little bit to include multi-specialty groups, perhaps employed physicians. So their goal is to throw out a wider net to collect as much data as possible. So it's not what you would traditionally understand to be a group as the individuals that you share an office with and practice the same type of surgery necessarily. Practitioners are exempt from reporting if they practice exclusively in groups with fewer than 10 practitioners, and this is meant to not be overly burdensome to rural physicians or physicians in very small group practices with limited resources. So what's reported? There's a full list of the 293 global codes available at this website, as well as on the ACS websites that we'll review in the resources. And these are codes for procedures impacting multiple specialties, including non-surgeons. So if you look at this partial code list, you can see these are primarily abdominal cases, laparoscopy, lap choles on there, but you can also see at the bottom that gastrostomy tube, hemorrhoid banding and injection. There are some 10-day global codes on there, but basically the code list has codes that would be applicable to almost every surgical specialty. So we encourage you to go to the site and review the list and see which codes are applicable to you or your specialty. So then what happens after you've selected these codes? So somehow these codes need to make it to the claim form. So in terms of the physician billing model, this model depends on surgeons using some sort of standard reporting process, and it may differ between individuals. So you use billing cards or slips, fee tickets, EHR billing lists, verbal communication with your biller or coder, and reviewing the report on a timely basis to make sure that you're not missing any data. You report all professional services, surgery, and visits on a timely basis, and the coder assigns the appropriate billing codes to all encounters. The surgeon or provider then determines if an encounter is related or unrelated to surgery. The coder is then responsible for entering the charges. They have an understanding of the global surgery concept. They know which codes apply. They know the appropriate CPT guidelines and modifiers to use, as well as the ICD-10 coding conventions for diagnostic codes, CMS guidelines, and assigning the appropriate billing codes and modifiers. Following this process for all surgery codes and for all payers, the practice management system then creates a claim that allows 99024 to file cleanly to the Medicare contractor. So in review, you perform a surgery, you report your surgery and create an operative note. The coder reviews your operative note, assigning the appropriate CPT and modifiers, and reviews the ICD diagnostic codes that are linked to your surgery. You provide reports of every encounter that happens as a post-operative visit with a diagnosis related to surgery. The coder then creates a claim using CPT 99024 and the diagnosis for surgery. So the key element is making sure that those hospital codes, those hospital visits that you perform, those number of visits get transferred to your office so that it can be reported on a claims form. If you happen to have other visits in the postoperative period that you would report because they're unrelated to surgery, your biller will understand how to use modifier 24 for a diagnosis or condition unrelated to surgery. And this would be something like a patient had a mastectomy and they show up within the 90-day global period with acute cholecystitis and they need their gallbladder out. So that's unrelated to the mastectomy diagnosis and procedure. Okay, so the next element is the practitioner survey. So this we don't know as much about at this point. We do know that it will be a national sample. We're not sure if it will be the same states or different states chosen to receive this survey. The goal is to get 5,000 practitioners and clinical staff, which would mean that they have to send out a lot more surveys than 5,000 to get that kind of a report back. And this survey is supposed to focus on the level of codes rather than just the number of codes. The 99024 is meant to capture simply the number of postoperative visits. How will the survey be conducted? Currently, the RAND Corporation is developing and conducting the survey and will collect and analyze the data and submit to CMS. We know very few details about the survey methodology at this point. It is supposed to start mid-2017, but we're almost there, and there are many unanswered questions, but we implore you to stop back at the website and we will update information as it becomes available. So let's look at some frequently asked questions. What if a practitioner within my TIN provides a postoperative visit? CMS determines that if care is transferred to another practitioner within the same 10, reporting is required. Now, we interpret this the same way we do cross coverage, where if you perform a procedure and your partner and your PA or whoever rounds on the patient while you're gone, those visits should be captured as postoperative visits and make their way to the claim of whoever those visits would normally be ascribed to. There are some circumstances where certain practitioners may perform a procedure and they have a relationship with someone who actually performs the postoperative care within their own group, and then that's considered a transfer of care. The example that CMS gave us was an ophthalmology procedure where then the optometrist performs a certain amount of the postoperative care. So the care is actually transferred to that person, which is different than what we would consider cross coverage. What if I or another practitioner within my 10 provide postoperative services twice in one day? CMS has interpreted this that there should be only one postoperative visit recorded per 24-hour period. What if I practice in 2 practices but only one meets the size threshold? If you meet the criteria in any practice, then you report all eligible postoperative visits. So even for the practice that doesn't apply, you should report all of your postoperative visits. Can visits be reported from all sites of service? Yes, visits can occur in all sites of service, including but not limited to the ICU, outpatient clinics, SNFs, or LTACs. How do I report postoperative visits? You report the process. You report postoperative visits using the usual process for filing claims. There is no need to link 99024 directly to the procedure, meaning you could upload those postoperative visits on a day different than when you upload your surgical code in a timely fashion. You don't have to put any time units or modifiers on the 99024. Is reporting required for Medicare Advantage and VA patients? Reporting is only required for traditional fee-for-service Medicare patients. How will the clearinghouse and provider software be updated to accept 99024? Basically, the responsibility is on you. You'll need to test to make sure that all systems are working properly and in advance, and you may need to attach a penny to the codes to make sure that they don't get scrubbed by your software. Should there be a validation plan for practitioners to confirm that all submitted 99024 codes were received? We suggested that this happen, but currently CMS has no plans for validation for you to get feedback that the codes have been received. If a patient comes in for a postoperative visit and needs unrelated care, should the 99024 be submitted along with the appropriate E&M modifier? Currently, CMS says that there should be one visit for a 24-hour period. Okay, let's recap. So the WHO is groups of 10 plus practitioners in 9 selected states. Anyone who wants to participate is eligible to participate. You don't have to be from one of those states, but those are the states that will be expected to report. You should report on postoperative visits for any of the 293 codes that are 10 or 90-day codes on the list. You can report all of your services if you choose. In fact, at our institution, we're choosing to report all of our postoperative visits because it will just be easier for the system to get used to recording postoperative codes and less burdensome to try to pick out individual physicians that are performing one code or another. How will it be recorded? You put 99024 on the number of post-op visits on a claims form and submit it in the same way that you would normally submit a claim during the global period. The start date again is July 1st. So what are your next steps? First, you need to verify that your practice meets the 10 practitioner threshold. And if you have any questions, we invite you to send your questions to directly to the CMS site, which will be on the resource slides. You need to determine if any procedures you perform are on the 293 list. And as I said, there's no penalty for reporting procedures not on the list or all codes if you choose. You need to develop a code capture strategy for all postoperative visits, hospital, office, or other, to make sure that you capture every code. And this includes trying to make sure that if you have a different EMR in the outpatient arena or office than you do in the hospital, some way to make sure that that data gets captured. So you make sure 99024 is recorded once per day for every postoperative visit performed, and you submit it on a standard claims form, plus or minus a penny. You need to document your postoperative care with the appropriate chart notation, because the key here is to document that we indeed are performing these postoperative visits, and that we have documentation within the chart which says that a postoperative visit occurred. Even though you aren't individually paid for those postoperative visits, it is bundled into your global service, and it's your responsibility to document the postoperative care that occurs. There's no need to hold the claims until all visits are reported. As long as the date range corresponds, you can record as you go or batch visits on a claim. You want to make sure that your office and billing staff are ready for July 1, 2017 implementation, and it's okay to start early. CMS assured us that they won't be using the data during the ramp-up period before July 1st in order to get a good data set. And we invite you to please participate in the RAND survey if you're invited. So what are the reasons to participate? One, it's a mandatory policy. Although there's no penalty associated with it, there may potentially be future payment withholds. Incomplete reporting will result in inaccurate data. Inaccurate data could result in reduced global code values. So at the end of the day, we are trying to capture as much work that we're actually providing so that it's a fair representation of the postoperative care that surgeons actually provide in that postoperative period of a global code. So even though there are a typical number of visits that are associated with a code, you may have patients that require more postoperative visits, and you may have patients that require less. We just want to make sure that we're recording accurate data. So here are the resources. At the top, the ACS webpage. You can go directly to that site and click that code, and it will take you to the regulatory and advocacy webpage, which gives you the information as it's being updated for the global codes. And you can contact the ACS at regulatory@facs.org. You can look at CMS and the Medicare Learning Network for some additional information if you choose. And you can contact CMS directly if you have questions specific to your group. And that's macra_global_surgery@cms.hhs.gov. So we have some time for questions.
As a reminder, to ask a question, make sure your audio controls are enabled, and then select the hand raise function, or you can also type your question into the questions tab. It looks like we have a question from Dana Grant. Your line is now open. Dana Grant, do you still have a question? Oh, okay, I see. The question has now been written. So the question is this regarding date of service July 1, 17? So I believe the question is asking about when the date of service should be, the date of service for when this policy starts. So the way that CMS has answered this question is that this, the 99024s should be reported starting July 1st, 2017. But the procedure itself could have occurred before July 1st, 2017. Okay, may we have a copy of the slides? Yes, we have recorded the webinar itself, and we can post that on our website. We can also post the slides themselves on the website. Another written in question is asking why this is so confusing and complex. Dr. Barney, would you like to address that question?
Well, actually, it's a lot less confusing and complex than what they had originally attempted to do, which was going to be this giant grid of G codes and 10-minute reporting intervals for every visit that you had for patients in the post-operative period, and it was completely untenable. There was no way that anyone would even make an attempt to do this. So, as I mentioned before, through significant advocacy efforts, the ACS and a number of surgical societies petitioned CMS to try to make this as simple as possible. Since people are collecting 99024s in their electronic medical records already, we thought that this would be the simplest way to give a numerical count of visits. And by mandate, they have to have information regarding not only the number of visits, but the more information about what happens in a visit, and that's what's going to be collected in the survey portion. So it's regulatory, and there's not much that we can do about it, but we've tried to reason it down to the most simplistic way that we could collect the data, because this data will be potentially used to revalue codes, and if we don't have a good data set, then there is concern that codes will be undervalued.
Okay, now we'll turn to some of the called-in questions. Robin Media, I see that you have your hand raised. Robin, your line is open. Robin, do you still have a question? Let's try Janet Cullum. Okay, maybe we'll just move on to some of the written questions. So this is an important question from Wesley Rippey. What if we use a code 99024 beyond the 90-day period because we don't want to charge for the visit? Do we still report those? CMS's answer here has been if a post-operative visit is provided after the 90-day period, that the 99024 code should not be submitted because CMS is considering that to be outside of the global period. Another question is, some procedures, including PEG feeding tubes, are performed by surgeons as well as gastroenterologists in our practice. Do both specialties need to report post-op visits for their respective patients?
These codes apply to any practitioner performing them. So this does not just apply to surgeons. So there are radiologists, dermatologists, family practice docs that perform certain procedures. Anyone who performs those procedures should report. So if a gastroenterologist performs the procedure, they should report it. If a surgeon performs a PEG, then they should report it. I don't know if you were asking if you reported it together like a shared code. I think under those circumstances, it would just be whoever the code gets billed to would put those post-operative visits in. You wouldn't double count them.
Okay. Our next question is the 10 practitioner threshold specific to the surgeons in the group, or does that number include non-surgeon practitioners in a multi-specialty group? So yes, all of the practitioners go toward the 10 practitioner threshold. So that includes surgeons, other physicians, and then non-physician practitioners as well. So it's easy to just see that number 10 and think that it just applies to the surgeons, but it applies to non-physician practitioners as well. Next question is, do we use the 99024 code on hospital rounds?
Yes.
The answer to that question is yes. Oh, yes. Go ahead, Dr. Barney.
No, sorry. Yes, every post-operative visit that's performed in the hospital is counted as a visit once per 24-hour period.
Yes, and this is important because CMS is collecting these 99024 codes in order to count the number of post-op visits that are provided. And we are stressing that every single post-op visit should be included in the count and none should be lost. And so that's why it's critical that the 99024 code gets submitted regardless of site of service. Another question is, in our practice, some patients require critical care, and the critical care physicians bill for critical care, and the operating surgeon bills for post-op visits in the hospital. Is this okay?
I see that as your post-operative visits that are attached to your surgery should be reported by the operating surgeon. If you are the person that's providing the surgery and providing some critical care, that gets a little bit more challenging because you don't want to not count billable services because there's no dollar amount associated with these codes. So if there's a circumstance where you are permitted to provide critical care services in addition to operative service, say it's on a trauma patient that you're doing ventilator management or something else, and you did some other surgical procedure that was unrelated. But in general, the critical care, if someone is providing critical care separately, they would separately bill critical care, and you would provide your post-operative visits.
The next question is, if I am a physician in private practice in a rural community, am I required to report? So this depends on, you could be required to report. The requirements are based on location. So if you provide post-op visits in one of the 9 states, if you are in a group of 10 or more practitioners, so that could be a few surgeons and a few non-physician practitioners. If you meet those requirements, then yes, reporting is required. One of the questions that we get is whether reporting is required for non-Medicare patients. So Dr. Barney had addressed this on one of the slides. Reporting is only required for Medicare patients. It's required for, not required for Medicare Advantage or Medicaid or VA patients. So only for Medicare patients. Next question is, if our practice was purchased by a university, our practice has only 4 surgeons and 2 PAs, do we have to report?
I think that would get down to what's your arrangement with your umbrella organization. So if you share the same TIN with that group, and that could include a family practice group, a group of a different specialty, and you meet the threshold of 10, then you would be required to report. Now, if you have a different relationship where you're not sharing the same TIN, but that gets to that slide that had these relationships where you have any sort of a business association that would count, that would be a question where I would direct it to that macro_global thing if you have any question, because it gets down to what they're defining as these sort of vague business relationships, shared address, shared services. To me, I interpreted that to be kind of an employment model in a hospital system where you may have separate groups, but they're under the umbrella of some sort of hospital association. But it's always good to check with CMS just to be sure.
Next question, I think this is a Dr. Barney question. What if there is an unplanned return to the operating room during post-op? Does this get captured without reporting the 99024? The diagnosis code would most likely be different in this circumstance. For example, a post-op infection.
So you would want to record that separately, because it's if it's a separate billable service for a return to the operating room, you would want to submit that service on the claim form as you would normally do. Now, the 99024s would continue from the original post-op visit as long as they're applicable post-operative visits during that global period. So I guess the question becomes, when do the post-op visits stop being for Operation 1 and start being for Operation 2? I guess my thought would be collect all of your post-operative visits, because the patient is still within the post-operative period. If you return the patient to the operating room on day 89 of your global, then certainly those visits would not be under the original surgery 99024. So the return to the operating room is probably not one of the codes listed on the post-operative 293 global codes included. So you wouldn't report separately for that. But I would count your post-operative visits as applicable.
And then the follow-up question here is, would these be reported on two separate claims?
I don't know how you would normally do that. I guess if you submitted your surgery on the day you did it, and then you had 2 or 3 global post-op visits that you submitted on a day-to-day basis afterwards, and then you had this other code, you would submit it separately. I think you'll have a different diagnosis code, so that will fall out on its own as an unrelated procedure. They said basically, you report it, you put the stuff on the claim, and somehow they're going to be able to sort through other stuff that shows up on the claim form during the postoperative period. So if you had an unrelated service, an unrelated E&M service, or you had a visit for something else in the office because you have a multi-specialty office, some physical therapy or something, that should get sorted out as different activities, but show up on the claim form, not necessarily the same day.
This is related to a question that we sometimes get about this issue, and which is, why is CMS doing this? Why is CMS making this new reporting requirement? And often our fellows will ask, I'm allowed to see the patient as much as I want in the post-op period, so why is this counting occurring? And our answer is yes. Surgeons are allowed to see patients as many times as they want in the post-op period, but they're only getting paid for a specific number of visits that have been determined by CMS. So on this screen, it shows, for example, in the open chole with cholangiogram, 1 discharge visit, 4 hospital visits, and 3 office visits. So these are the 8 visits that are paid for. And for example, if a patient were to be seen 5 times in the office or just once in the office, the payment is still for 3 office visits. And this is what CMS is looking at and questioning, whether 3 office visits actually occur. So again, this is why it's so important that every 99024 gets submitted, because we don't want it to look like fewer visits, fewer post-op visits occur than are actually being provided. Next question is, We also have a provider who sees patients under 2 different TINs at our facility. It is usually for a Mohs closure. If this is during the post-op, but the procedure was billed under a different TIN, do we report that 99024?
I guess it would depend on if the procedure that's being performed is on the list, number one. The second would be if the person's in a different TIN, it doesn't matter if they meet the threshold to have to report the codes that they provide. So if the plastic surgeon is performing this closure procedure and it's on the list, then they would be expected to report those post-op visits for their procedure, and you would be reporting the post-operative periods for whatever dermatologic procedure was done with the Mohs procedure. So 2 people can be reporting post-operative periods if they're doing separate operations that are on the list. Because that would be like an orthopedist does, nails a femur, and you take somebody's gallbladder out at the same hospitalization. The 2 of you are providing separate post-operative visits that should be captured unless only one person has been designated as the person providing post-operative care. I think this issue comes up a lot with the belief that there's a practice that perhaps a hospitalist is providing your post-operative care and that the surgeon is not providing any post-operative care. And we want to make sure that when post-operative care is being provided, that it's being captured.
Our next question is, if I'm seeing my partner's patient during a post-op period and I did not participate in the original surgery, is it a post-op visit or a clinic visit?
Unless you transfer the post-operative care to someone formally, put a 55 modifier on a code that says that this person is providing only post-operative care. Under those circumstances, I would interpret that to mean you're cross-covering, basically. So I would envision that as that post-operative visit goes, a claim is recorded, but it's probably ends up being assigned to the surgeon that did the procedure, because maybe you're seeing them that day because they're out of town or they're caught in the operating room. You're cross-covering in the same way someone would cross-cover for you if you weren't available, but you're still within the same group, the same TIN. You're not a separate person providing only post-operative care.
The next question is, and I apologize, Dr. Barney, I think this is another one that you are better able to answer. If a procedure is done, for example, breast excision, and a few post-op visits are done to review new imaging and discussions for subsequent surgeries, is only the 99024 allowed, or can we charge for office visit and discussion using time as a qualifier?
I think that's kind of, you have to be a little careful with that. If your visit meets the criteria for an unrelated service in the postoperative period, then you can bill as an unrelated service with a 24 modifier. If it's postoperative care and you're reviewing pathology and it's within the global period of a procedure, you can't really, I don't think you can really bill for that under those circumstances. I think you'd have to look specifically. If it was a biopsy code and there was a 0-day global associated with it, then you certainly could bill for each of those visits, and you would bill it as a code where counseling and coordination of care occupied, a larger percentage of the code to get you up to a level that meets you spending 45 minutes or an hour with a patient. But the rules still apply that if it's for the same, the same related procedure in the global period, you can't bill for those global visits.
And I believe that answer also applies to the next question, which is, if we have numerous providers in our group who provide different follow-up care, does each provider report the 99024, even if they are not the provider who rendered the initial surgery?
So yeah, if it's a PA working under your supervision or a nurse practitioner, I think those would be considered kind of an extension of you, because if they were seeing that patient for a billable service, they would be able to bill for that service. Whereas if it's a resident or a student in the office, I scratch the student. If it's a resident operating with you, their work product is not separately billable under a circumstance outside the global, so it wouldn't be, reportable under the global. You'd have to be the supervising physician and sign off on those notes in order to count it as a post-operative visit. You have to meet the teaching requirements to count it, I guess.
So that looks like all of our questions for now. I'll also mention another question that we sometimes get is asking about just the logistics of whether CMS contractors and clearinghouses and the provider software will all be allowed to submit the 99024s. And CMS has said that they're working with their contractors to be able to collect the 99024 codes and put them in a database at CMS. We strongly encourage testing of your software and making sure your clearinghouses won't kick out these claims. And if you have any problems, please email us at regulatory@facs.org. F as in fellow, ACS, American College of Surgeons.org, because then if there's problems with clearinghouses and software, we'll collect those and let CMS know that certain codes are getting kicked out. Because again, our goal is to make sure that all of the codes are collected.
And
another question.
I'm sorry, go ahead.
Yes, go ahead, Dr. Barney.
I was going to say, we realize that this seems burdensome, but it's so very important that people participate, because a very low return rate of reporting of globals will allow for an interpretation that maybe these post-op visits aren't actually occurring, and it can have significant valuation ramifications going forward.
That actually leads us to our next question, which is, what is ACS's strategy to monitor compliance? And will CMS be able to extrapolate the value based on the data provided, even if it only represents 20% of practicing surgeons? So as far as the number of surgeons that are asked to report, CMS is asking surgeons in these 9 states. The law, MACRA, that authorized this policy requires CMS to only make this policy apply to a representative sample of physicians. So CMS is somehow intending to extrapolate the data reported by these 9 states to the rest of the country. So we have raised a number of concerns about what CMS will do with the data, and we're going to be continuing to monitor and advocate on behalf of ACS fellows when it comes to the point of CMS in some way using the data to revalue global codes.
And again, since we don't know what's happening with this survey, we have really not much of an idea about what's going to be on the survey, how complicated it's going to be. I think the first blush is that it's going to be a lot more complicated than recording 99024 post-operative visits, which many people already do. I think it'll be really important for people, if you receive the survey, to contact the ACS if you have questions regarding how this is, how I'm supposed to get this data and how I'm supposed to fill out this survey, because we have no idea currently.
And one of our last questions is, do you think this could provide higher reimbursement in the future? That's a great question. We're actually very worried that if accurate data are not collected, that CMS might be able to reduce reimbursement in the future. And so that's why it's so important that the correct number of 99024s are reported to represent the work that surgeons do. And again, there won't be, as we mentioned earlier, there's no penalty for not reporting, and lack of reporting won't affect payment right now. So it won't affect payment for the services that are currently provided. But if CMS doesn't collect accurate data going forward, CMS could then use that data to change the value of global codes in the future, in 2019 or later. So with that, we're at 8 o'clock. Again, this webinar will be recorded and put on our website. Dr. Barney, did you have any final thoughts?
I don't think so. Just stay tuned, and we encourage you to go to the ACS website often, because we'll try to put updates on there as soon as they're available. And if you have questions, forward them so that we can try to get these questions answered and update some additional frequently asked questions onto the website so that others can use those. And then if you look on the little handouts tab of your webinar, you can download the one-pager, which gives you information that basically it's the tip sheet of what we talked about tonight, so that you can pass them around at your hospitals so that your other surgical colleagues can get their questions addressed.
Okay, thank you everyone. Have a good night. Bye-bye.